All right, so we will go ahead and get started. This meeting is being recorded, so for people who join in a little bit later or aren't able to join us today, they will get the recording later. So hello, everyone. I'm Maddie Dix. I'm the Alumni Coordinator for the School of Nursing. And welcome to the 5th session of the School of Nursing's Hubs Research Series. As part of a top-ranked research university, the School of Nursing offers research programs aimed at advancing nursing practice. The school is home to 6 research hubs, which provide funding opportunities to foster collaborative, interdisciplinary research programs. The hubs feature multiple faculty members and students with similar research interests, pursuing pilot projects on similar topics and/or themes, or integrating multiple existing projects as to benefit from leveraging their resources and expertise. Today, we are pleased to present the Excellence in eHealth Research Hub. Now more than ever, technology is changing the way we do everyday health, from sensor systems to different technologies, internet functionalities. These technologies hold promise for promoting health, well-being, and reducing disparities. We are excited to welcome Dr. Annette DeVito-Dabbs, Dr. Youngjin Lee, and other School of Nursing faculty members to discuss the research happening within the School of Nursing that are harnessing these novel technologies to improve healthcare and health outcomes. We've pre-recorded the presentation, so I will share my screen momentarily for you to view. However, we are joined by these 2 co-directors of the hub for a live Q&A after the presentation. So if you have any questions at all, please feel free to add them into the chat function, and I will monitor after the presentation. So without further ado, I will share my screen. All right. And yep.
Hello, my name is Annette DeVito-Dabbs, and I'm also with Dr. Youngjin Lee as the Director of the Hub for Excellence in eHealth Research. We're happy to be giving you this overview today, especially to alumni of Pitt School of Nursing, because we are so proud of all of you. First, eHealth is defined as the use of emerging information and communication technology. This includes such things as the internet, mobile apps, all to improve or enable health, well-being, and healthcare. These technologies hold promise for promoting health, well-being, and reducing disparities for individuals and groups. The overarching goals of the eHealth Hub are first to coalesce efforts of those who are conducting research in the eHealth space. Second, to share a range of methodological issues and perspectives. Third, to support the inclusion of patients and consumers in the co-creation of eHealth solutions to maximize their benefits and reduce their risks. And fourth, to support the development of students and new investigators. There are several underlying principles of our work, the primary one being design justice, which is defined as how the design of technologies influences the distribution of risks, harms, and benefits among various groups of people. Design justice considers variation in availability, access, and acceptability of the proposed solutions. Our work is also based on equity design thinking, which is an approach to design that first involves stakeholders, particularly marginalized communities, as co-creators in all phases of the design and evaluation process. Also, equity design thinking overcomes power differentials that lead to exclusion, oppression, and health disparities. And third, it connects the design of health technologies to larger struggles for collective liberation and ecological survival. The School of Nursing received NIH funding to develop an educational series on equity design thinking. When I say co-creation techniques, I mean involving patients at the table from the ideation of the possible tech solution all the way through to the interface, navigation, functionality. It's a transdisciplinary enterprise. Those who are involved in the eHealth Hub represent all disciplines. We also are designing technologies for all sorts of populations, settings, using a variety of devices and platforms to examine questions such as, does eHealth promote better health outcomes? If so, how and for whom? What makes eHealth solutions acceptable and useful to patients, consumers, and clinical providers? And then how to translate effective eHealth solutions into real-world practice. We also ask the question of who's involved in the process, who might be harmed, and who benefits. Today, I'm going to briefly give you some snapshots of some examples of projects led by Pitt nursing faculty with our interdisciplinary teams that are supported by peer-reviewed funding sources. And the projects all include graduate and undergrad students in the process. This will be followed by a few vignettes that have been previously recorded with a little more detail on a few of the projects. The first is a cognitive behavioral therapy mobile work app by Dr. Judith Callan to help ward off and work on the therapies and homeworks associated with cognitive behavioral therapy for depression. Another is Dr. Dan Lee, who is an engineer and a nurse, and she's examining ways to visualize pressure ulcer injury assessment so that over time you can look at changes in these images to determine progress towards resolution or healing, rather than just eyeballing or using the typical measuring tape sort of assessment that we've all been taught to do. The other is with Dr. Sharon Krchanik, who is the principal investigator for an intervention called Ready Girls. Her work is helping young women with diabetes to make good reproductive choices and planning. And this work has also been adapted for Indigenous peoples and American Indian tribes and other groups. One of my projects, Pocket Path Synergy, is the combination of providing patients with apps on their phone and with data that's transmitted to a dashboard website for clinicians and the patients to look at and review to help detect any issues or problems after lung transplant. Another one that I am the PI for, it's a multi-center trial with Dr. Foster at McGill and several other institutions around the US and Canada. We are looking to help reduce medication non-adherence after transplant for adolescent and young adult kidney patients. And we have been involving them in the development of an e-pill box, electronic pill box, involve a coach and the website. And they've been involved in every step of the way, both patients, clinicians, and parents for those who are under 18. The other project I'm doing is called LT Go, which is a multi-component tele-rehab exercise intervention, again, for patients after transplant. This one is a randomized trial to evaluate individualized supervised exercise programming via telehealth for and the behavioral coaching skill sets for patients after lung transplant. And they all include self-monitoring of activity using Fitbit and other devices, and we follow them for 6 months. The eHealth Hub also has a special interest group for undergrads that's led by Dr. Youngji Lee. So we are encouraging their involvement as early as possible in these projects, as well as the undergrad research mentorship program, where undergrad students are paid to work 5 hours a week on research projects. So all of these projects include undergrad students, and many of them include graduate students as well.
Hi, my name is Jamie Zelazny, and I am a junior investigator in the eHealth for technology research. I want to talk to you today about my area of research, which is using technology to identify and manage suicidal risk in youth. So just a little background for most of the research that I do. Suicide is the second leading cause of death among young people. Even though a fair amount of research has been done in this field, it's still really difficult for us to predict imminent risk and which kids are in imminent risk of suicidal behavior. Part of the reason for this is that clinicians rely heavily on self-report from their patients, and the addition of objective measures and objective assessment methods can be very helpful in adding to our ability to predict risk. Some of the technology that I've used in my research includes, I'm part of a team that developed a suicide prevention app. I'm also collaborating with investigators at Carnegie Mellon University, trying to identify voice and facial indicators that might predict suicidal behavior. The study that I'm going to talk with you about today is focusing on social media risk factors and ways that we might be able to use social media to predict risk for suicide in teens, eventually using methods of natural language processing. So the study I'm going to talk about today is the SMART study, which is social media assessment of risk in teens. I co-led this study with Candace Biernesser, a colleague of mine in the Department of Psychiatry. And our co-investigators include David Brent, Neil Ryan, and Tina Goldstein, all in the Department of Psychiatry at Western Psych. The study was funded by the Once Upon a Time Foundation and also by seed money through the University of Pittsburgh School of Nursing. As many of you know, if you turn on the news or read the newspaper or scroll the internet, there are many headlines that point to a connection between adolescent suicide and social media use. If you just compare suicide rates in the last 10, 12 years from 2007 through 2018, and put that side by side, a chart that looks at the increasing rates of social media use during that same time period, you'll notice that they have a similar shape. Now, I'm not saying that social media use is causing an increase in suicide rates, but it's worth further investigation and trying to understand more about any connection that might be there between social media use and adverse mental health outcomes in youth. There have been a fair amount of studies that have shown that social media use or excessive social media use has been connected with a variety of adverse mental health outcomes, including depression, eating disorders, poor self-esteem, even suicide attempts. Cyberbullying also is a big piece of this as well. So for this pilot study, it was a cross-sectional case control study. It was approved by the University of Pittsburgh Institutional Review Board. And we basically enrolled kids who were aged 13 to 18 and who had at least one social media account. Within the attempter group, they had to have had a suicide attempt in the past 9 months, according to the Columbia Suicide Severity Rating Scale, which was part of our assessment battery and is a commonly used measure of suicidal behavior in both clinical and research practice. In the control group, they had to have no lifetime history of suicide attempt or non-suicidal self-injury and no history of a serious psychiatric diagnosis per our assessment instrument. We initially conducted these studies in person in our offices in the Department of Child and Adolescent Psychiatry. Obviously, with the pandemic, we had to change procedures up and we moved to remote visits. The study basically consisted of 3 major parts. We conducted a psychiatric diagnostic assessment using the MiniKid, the A-Life, and the Columbia Suicide Severity Rating Scale. We completed an entire battery of self-report questionnaires that were given to the youth. They were completed electronically. And we collected their social media data from the past year for future natural language processing using a collection method called open authentication, or OAuth. For the self-report questionnaires, which is what I'm going to talk about today, these were completed electronically on a tablet during office visits or by phone or device during their remote visits. We also assessed both risk and protective factors. Just a quick look at our sample. So we had 20 attempters and 20 controls. There weren't really any significant differences in their demographic characteristics other than household income, where the non-attempter group had significantly higher household income than the attempter group did. But just in general, just some overviews. Our sample was primarily female, primarily white, primarily non-Hispanic, and we only had 3 gender minority youth, and they were all in the attempter group. So it wasn't an extremely representative sample. So I just want to highlight a few of the results. So the Prius measures problematic internet use in youth, and it consists of 3 subscales and a total score. And every single subscale and the total score, the suicide attempters had significantly higher scores than the non-attempters, meaning that they had significantly higher problematic internet use. They reported more social impairment, more emotional impairment, more risky impulsive internet use, and their total scores were also significantly higher as well. And looking at sleep, most of the youth in the study, both the attempters and the non-attempters, used social media in the hour before sleep. So, and there were no significant differences between groups here. We also asked participants to subjectively report how much they felt that social media interfered with their sleep. And this was significantly higher in the attempter group than the non-attempter group in terms of the number of youth who reported moderate to severe interference with sleep as a result of using social media. We also completed questionnaires with youth that kind of measured if their peer experiences on social networking or social media sites. And again, the suicide attempters reported significantly higher scores indicative of negative peer interactions than non-attempters. And another important measure that we look at is the term is upward negative social comparison. And this is a trait that we've found to be elevated in attempters compared to non-attempters in other samples. And in looking at the social media use in this sample as well, the suicide attempters were much more likely to report significantly more likely to report higher scores that indicate that they were comparing themselves negatively to peers on social media use. So the way that they describe this to us is, their friends seem to be happier, seem to be leading better lives, seem to be accomplishing more. And so they're comparing themselves in a negative light compared to their peers. A few limitations, obviously it's a small sample size. It was a pilot study, predominantly white, non-Hispanic sample. Our sample is just not extremely representative. So we definitely have to do better in our larger study. But it's hopefully coming next. In conclusion, the youth suicide attempters reported significantly higher negative experiences on social media than the controls. It may be that youth who are experiencing mental health difficulties or who have made suicide attempts might simply just be more vulnerable to the negative impacts of social media. It may be that their coping skills or their problem-solving skills or their emotion regulation is not working as well as youth who don't have these mental health pre-existing problems. And we definitely was a case control study, so we weren't really looking at causality. We were just comparing characteristics between the groups. But further research is needed to explore the underlying vulnerabilities that might contribute to these findings. In terms of next steps, we are awaiting a final funding decision from the National Institute of Mental Health on an R21 exploratory grant to study, to continue the study in a larger sample and using new methods for collecting social media data. We did get a fairly good score on this grant, and so we're hoping that we will be receiving funding in the future. Thank you very much.
Hello, everyone. This is Dr. Salah AlZaiti. I am an associate professor at the School of Nursing, and I have joined appointments at Emergency Medicine and Cardiology. So my research is at the intersection of biomedical informatics, machine learning, and cardiac emergencies. And specifically, we look at intelligent ECG methods for myocardial ischemia detection. We have received a patent from the Innovation Institute here at the University of Pittsburgh for this work, and we have numerous sources of funding internally and externally, namely a grant from National Heart, Lung, and Blood Institute. So our study is called EMPIRE, Electrocardiographic Methods for the Prompt Identification of Coronary Events. And it's a joint collaborative effort between nursing, our colleagues at emergency medicine, Pittsburgh EMS division, Division of Cardiology, and computer and electrical engineering. So the unmet clinical need. Almost 7 million adults come to an emergency department annually in the US with acute complaint of chest pain. The very first thing that we do as providers is to get a 12-beat ECG. They are very good for identifying almost 2% of patients who are having a STEMI or an ST elevation myocardial infarction. These patients go directly to the cath lab. The problem is 98% of these 7 million patients do not show that feature on the ECG. We follow that up with 2 to 6 hours in the emergency room with blood draws, biomarkers, clinical assessment tools. These biomarkers are problematic, so they do not show us what's going on from the first draw. So we might end up doing serial sampling. And eventually, we can identify a small subset of patients to go home, but almost 65% of patients get admitted. And after almost 2 days of provocative testing, stress tests, cath or angiograms, perfusion mismatch scans, SPECT scans, we end up identifying roughly 10% who actually have coronary disease and they need an intervention. It would have been great if we identified these patients 2 days earlier when we did that baseline 12-beat ECG. So right now, we end up with a current paradigm where most commercial ECG interpretation systems, as we see to the left, they can identify roughly 30% of patients with coronary disease, and the other 70% of patients simply get missed. And the long story short, this has to do with the vector-based nature of the ECG, where if you have 2 ischemic regions on the heart, as we see in the figure to the right, they simply cancel each other, and you end up with a clean ECG. So what can we do about it? And this is the essence of our research. We have investigated numerous novel approaches for quantifying regional heterogeneity in the signal, looking at the heart in the 3-dimensional model, and looking at a spatial aspect of the signal, and things like principal component analysis. We were able to successfully isolate a subset of novel features that can actually capture myocardial ischemia, and they are beyond the ST segment, so they are beyond what you can evaluate for STEMIs for the rest of the 10% of patients who have coronary disease, but no STEMI manifestation on their 12-beat ECG. So our study has been going on since 2013. It's published on clinicaltrials.gov. And we are recruiting patients who call 911 for chest pain and being transported by Pittsburgh EMS to either EBMC, Brisbane, Shadyside, or Mercy. Their ECG is being transferred to the medical command center. So these are the most vulnerable patients where a decision really need to be made early on. And our study has been recruited over multiple cohorts. Over the years, we have screened almost 800 patients. We enrolled almost 4,000 patients in this study. And our ECG analytics pipeline, led by our collaborators from electrocomputer engineering, is very sophisticated. We go into the details of the signal, we featurize, isolate, segment, extract features, and eventually build models. And our prototype algorithms were based on AI and machine learning. We have explored numerous approaches to build these machine learning classifiers. And without getting into the details, here we see a comparison of almost 10 different novel classifiers. One of them that worth mentioning is what we call random forest, that did a great job during training and during testing maintained its performance. And to put that into a perspective of clinical numbers, when we compare our performance to a commercial system, as I mentioned earlier, that commercial system has simply 37% sensitivity. We were able to bump that up by another 30% or 35%. And that's considered tremendous clinical gain. And when we look at the overall picture, our reclassification performance, something called NRI index, is almost 25%. So out of the 7 million patients who get evaluated for chest pain annually, you can reclassify 1/4 of these patients correctly. Whether this is a patient that really need to go into a cath lab, or this is a patient who really can be sent home safely. And right now we are moving into our second phase, and we are trying to build these analytics at the bedside to impact patient care. So we are exploring a real-time pipeline where we are intersecting the signal that gets transmitted from the field to UPMC clouds, and we are building a viewer where that intersected signal can be viewed by physicians at the medical command center. And this is a visualization of how our graphical user interface looks like, easy to use, very simple. In addition to viewing an actual ECG, our machine learning models can show you predictions. This is the likelihood of an actual atherosclerotic disease. That's where that occlusion might be. And there's a probability forecast for 30-day outcomes that can really inform decision-making in real time. Still, this is an ongoing work. It's going to take another few years to validate the system before eventually it becomes a standard of care at the bedside. And 1,000 thanks to our colleagues from emergency medicine, EMS division, cardiology engineering, and our work was featured on Bitwire a few months ago. And thank you so much for listening.
Hello, everyone. It is delighted to meet you guys virtually. I'm Youngji Lee, Assistant Professor in the School of Nursing and the Departments of Biomedical Informatics in the School of Medicine. And also, I'm the Co-Director of Excellence in eHealth Research Hubs called eHealth. Well, today, I'd like to quickly introduce my research, but before moving on, I just want to give you the backgrounds of what my research is for. So, when we have questions about our symptoms, medications, treatments, or doctors, whatever related to the health, we go to the internet and looking for the information. Nowadays, there is a joke called the Dr. Googles. So the internet has been a prominent source of health information to guide patients and caregivers' decision-makings and many of their self-health management activities. So one of the studies showing that 72% of adults in the United States have used the internet to search for health-related information. So internet has been a really great friend for us to telling us about health information. However, not everyone are able to look for it. So people reported that they are overwhelming by the vast amount of unfiltered information. And sometimes they don't know what is the right information from them. So one study showed that 91% of online health information seekers indicated that they need some type of navigational support to locate appropriate health information. So our study is building the health e-librarians with personalized recommender systems, which is called the Helper and supported by the National Library of Medicine. This is a 4-year studies, and now we start our year 3. So Helper study is to building the libraries for ovarian cancer survivors and their caregivers. And also we wanted to replicate and expand the traditional positions of health librarians in modern online world. So just imagine that if you have any questions about your treatments or the symptoms, but you don't know what information resources that you need to look for, so you go to the health librarians and asking for the right resources. However, you are unable to access to the health librarians during the weekends or the night times. But if you have, then what should we do? So our helper system try to be the virtual health librarians to helping people to navigate the right informations and personalize the informations based on their needs, their interests, and also their disease-related knowledge. And while we are recruiting ovarian cancer patients and caregivers, but also we are collaborating with the National Ovarian Cancer Coalitions to access to the their online forums to understand the patient and caregivers' needs, perspectives, values, or concerns that are written in the online health communities. So we are going to incorporate this patient-generated health information written in the online health communities to build our algorithms. And also these users are going to provide us the feedback to improve the systems by collecting and recommending information to the others. So this is one of our research, but when you join to the eHealth Hubs, you are going to have more opportunities to learn about the nursing researches that are related to the health ITs, technologies, the mobile health, algorithms, machine learning, and so on. So please feel free to reach out to us if you have any questions. Thank you.
Hello, I'm Laura Burke. I'm a professor in the School of Nursing, and I'm a member of the eHub for Excellence in Mobile Health. I'm going to spend the next few minutes talking about my latest clinical trial called SMARTER. I would like to acknowledge my co-PI as well as my total investigative team and the research team, as well as the National Heartland Blood Institute that funded this study. So for the past 20, 30 years, I have been focused on the prevention of cardiovascular disease, and the clinical population are individuals who have overweight or obesity, which is a highly prevalent. Today, over 70% of US adults are afflicted with overweight or obesity. Unfortunately, there are many comorbidities associated with this condition. So standard behavior treatment, which is a well-established protocol that has been used in multiple multi-center studies trying to prevent diabetes and cardiovascular disease related to it, has provided extensive evidence on the success of standard behavior treatment. It's the most efficacious approach. However, it is intensive, burdensome, and has limited availability to the millions of individuals who need treatment. So related to this, the core of standard behavior treatment is self-monitoring. My team, as well as others, have added to this increasing body of evidence supporting the role of self-monitoring and how it is the center part. So on an earlier trial, we used innovative mobile technology to provide real-time feedback to the self-monitoring and demonstrated we can improve lifestyle habits. So today we are focused on increasing the access among individuals who need this treatment, particularly those who are not interested in the structured program or who are not able to attend an in-person program. So we would like to focus on remotely delivered feedback. The purpose of the SMARTER trial was to test the efficacy of adding automatic feedback to smartphone self-monitoring and look at the difference between those who receive the feedback and those who do not at weight loss at 6 and 12 months. The design of SMARTER is a two-group randomized controlled trial. We enrolled 502 adults with overweight or obesity with equal allocation to either self-monitoring alone or self-monitoring plus feedback. For the intervention, at baseline, all participants had a 90-minute one-to-one session, meeting with the dietitian focused on behavioral changes to target weight loss. Also, all participants used smartphone app, a Fitbit Charge 2, and a digital scale to track their behavior changes and self-monitoring of food intake, physical activity, and weight. Only the self-monitoring plus feedback group received up to 3 feedback messages per day, which appeared as pop-up messages on the smartphone. The messages were tailored to what they had entered in the self-monitoring records, and the messages were delivered at random times during the waking hours. This slide shows you examples of the feedback messages and how they address all the various behaviors. So in the study, only one of these messages would be delivered at one time, so only one message on the screen, and the message only focused on one behavior, such as added sugars or sedentary behavior or physical activity, etc. So a sample of 502 was predominantly white and female with a mean age of 45. They were well educated, and the body mass index indicated that the group was essentially in the obesity category. So our preliminary findings at 6 months did not support our hypotheses that participants in the self-monitoring plus feedback group would show greater weight loss than those in the self-monitoring only group. However, both groups demonstrated efficacy, with approximately 30% of both groups achieving a 5% weight loss, which is clinically significant. The final outcomes will be reported at 12 months, and we are currently analyzing those data. And at 12 months, we will determine again if weight loss the feedback group is superior to those who did not receive feedback. We will also address a major gap in this literature, and that is focused on sustainability of engagement with mobile devices. So we will be measuring adherence to the study protocol at 3, 6, 9, and 12 months, and reporting this in detail. And then finally, we will be exploring some exploratory aims, looking at relationships between the feedback messages sent and the subsequent behavior. So this is, I think I'm probably out of time. I would love to have some discussion or answer any questions in a future meeting, and look forward to sharing our results later. Thank you very much for your attention.
All right. So thank you so much. It's wonderful to see all of the great research that's happening. And there's such a wide array of happening in this hub too, you know, from suicide prevention to weight management. It's kind of all over the place, which is really very lovely to see. So there are a few questions that have come up. If you guys have a few minutes, that would be great. So the first one that came up is, you know, because that we are in the middle of a pandemic where, you know, people aren't leaving their homes. Is there...
Sorry, you're breaking up, Maddie.
Oh, I'm sorry. Can you hear me now?
Can you repeat the question?
Yeah. Because we are in a pandemic and, you know, people aren't leaving their homes, has there been an increase? Have you guys noticed an increase in eHealth during the pandemic, and how is that going to affect your research long term?
Well, I'll start with the response. One of the advantages of technology or digital supported interventions for health is the ability to reach people remotely. But at the same time, it leaves some people behind if they're not used to using digital resources or have access or broadband in their home. So there's been an impact, but we have been continuing most of these studies doing everything remotely. And in fact, we're contributing to how people are learning to interact with people in the remote environment. So it's been a challenge, but it's also brought new opportunities for things like mobile health, telehealth, lots of other things. As long as we remember that it's not going to meet the needs of everyone, that we have to make sure we reach out to those who may not be used to or well acquainted with technology.
Yeah, so I echo to what Dr. DeVito said. So during the pandemic, there's a huge increase in the eHealth, electronic health, digital health researches, not only from us, but also, you know, the internationally. And like Dr. DeVito mentions that there is a people who left behind, you know, not only having the access to the digital health, but even they have the access, they don't know how to use it, how to interpret it, or how to digest all the information. So I think this can give us a really great opportunity for our undergraduate students who will be the future neuroscientists, that, you know, not only for, you know, engaging in the current ongoing researches, but I think our hub can bring up the many issue, you know, discussion question and issues related to the digital divide. And as a nurse, how can we, you know, bridge the gaps? So ultimately everyone's, you know, hopefully everyone have the you know, equal access to the digital health. And I know we also have the course offered from the Dr. David Dabs related to the you know, the eHealth and also the equities and the ethical issues, right? Yeah. Yeah.
Yeah, we gotta engage those current students a little bit, get them to be on the, get them to become the best nurses that they possibly can.
Yes.
So kind of going off of that, I know that you, we talked a little bit about it in your overview of it, Dr. DeVito Dabbs, with the special interest group for undergrads. Is there other ways that current students can get involved, whether it's, you know, research or other things like that? How can they get involved within the eHealth hub?
So are you referring predominantly to undergrads or any level student?
Any level student, yeah.
Okay, so if you've heard other hub presentations, you've probably heard about the undergrad research mentorship program. That's open to any undergrad student who wants to start working with any project at all. So as I mentioned, all of these examples that we gave, plus other people in our hub that we didn't highlight today, all involve undergrads in their projects. And as one gets involved, then they pull in another friend or another. So some projects might have 4 to 6 undergrads working on it. And the other thing is we try to promote, not only do they get exposure to a real world research project, but they get involved in asking their own secondary questions. And then we help them formulate an abstract for presentation or do a mini study of their own. So by the time they graduate from the school, they have some things on their CV to demonstrate their commitment. We also have ongoing workshops and presentations and things that the whole school is invited to. So I don't know, do you have other things you want to say, Youngji, about the state?
No, I think, well, in addition to that, so if it's all levels of the, you know, the eHealth, I mean, you know, also all of the studies are looking for opportunities to be involved as to the research apprenticeships. Like if you are in the PhD programs, you can also be a part of it through the research apprenticeships and learn more about it. Yeah.
Awesome.
E&P students as well. It's not,
yes,
not just the research focus, but our projects, because we interface with actual patients and providers and health systems, it's hard to find a project that doesn't have some connection to technology that you might benefit from hearing what other people are doing.
Yes, so currently, like in the current helper studies, we have the undergraduate, DNP, and also the PhD students. So all levels of the PhD, you know, nursing students, even who doesn't have any backgrounds in computers or information science, they are learning from the projects and contributing to, you know, the health technologies. So if you guys are interested in these, you know, there are many researchers that can help you to learn about the eHealth.
Awesome. That sounds great. It sounds like there's a lot of opportunities for everyone to get involved, which is lovely. That's great. There's just one last final question. So of course, like everything revolving research, there's the aspect of funding. What does funding look like for, you know, your specific projects or just the hubs in general? Like if you were to receive all of the funding in the world, what is your dream for the hubs long-term wise?
Well, the focus of the hub has always included the development of junior researchers and to help with pilot work, to help launch what they're going to do next, that they might not be able to get funding for directly on their own yet because it's such a budding idea or still needs to have some other preliminary data. So we try to focus, and we always could use more of funding targeting pilot projects, and then we can continue to support the investigator to keep going and getting their own funding eventually. The other thing is that the school established the hubs because it does help to cluster people with like interests and zero in on some shared resources. So we're also hoping, all the hubs are hoping to establish some sort of a more funded, sustainable center for each of these hubs. And that takes a cadre of well-funded people to begin with, so that an outside investor would say, those people have a track record and they're worth supporting. And they also typically want to see that even if it's nurse-led, which all of our projects are nurse-led as the PIs, we have colleagues, because we can't do this ourselves. We need engineers, we need computer scientists, we need technicians. So again, an outside support for that sort of machine that's in place to accomplish this work. Any other specifics maybe Youngji can add to this?
Well, yeah, everything's already, Dr. DeVito that mentions really perfectly. But just in addition to that, I hope that our hub can be the hubs for the researchers and students to be connected with the other researchers outside of the nursing, but who are also interested in health technologies, so we can build more interdisciplinary team for future.
And if I could add one example to that I mentioned a little bit on our introductory video, is that the School of Nursing did get a special grant to develop an educational series on equity design thinking. I already introduced the concept, but this was a real coup for us to get this funding, because it's been over the last year and a half that health disparities have really come to the forefront. And design justice also is based on the fact that many health disparities could be averted or avoided if the vulnerable groups were involved in the development of the technology from the start. So we're going to be making that educational series available starting in January. And it'll be open to anyone, open access, free, 10 modules worth of information. So maybe we could highlight that again, maybe next year.
Yes, absolutely. That sounds wonderful. Yeah, we'll definitely have to promote that. Well, I think that is kind of it for today, but I would like to thank you both for sharing all of the wonderful research happening within this hub and at the School of Nursing specifically, and a thank you to the wonderful faculty members also featured in the presentation for sharing their research as well. And finally, a thank you to all of you for attending this virtual event. We are grateful that we could spend some of your day with you. If you have any additional questions, please feel free to reach out to me. Thank you once again for joining us. Have a wonderful rest of your Monday, a great week, and hail to Pitt.
Thanks, Maddie.
Yeah, thank you.
Thank you both so very much. Have a great rest of your day.
You too. Bye.
Bye.